Hi, everyone. My name is Shabir Musa. I'm a family physician in Johannesburg. I'm also the president of Wonka Africa. And we're very fortunate in having a really great panel. This is a webinar that is facilitated by or organized by Wonka Africa, the Afro-PHC as an organization bringing the primary health care team together, as well as the WHO. As I said, we are having these webinars on a Friday afternoon looking at the primary health care response, and we're very grateful to have a panel from the Cape Town area, Western Cape, led by Bob Mash, and I'll introduce him to you, and he'll introduce the panel shortly. I just want to go through quickly how you use this. Please raise your hand if you would like to speak. We'd like to have some people who offer to share their comments and add to this. I think there are quite a few people from the Western Cape that might be there, or others who feel they like to ask questions. We do have an opportunity for you to check your settings, also to check your Q&A. So if you have any questions, please use that rather than chat, which is the next one where you can see on the right-hand side, right bottom corner, that you can direct your chat there. But please use the Q&A. And then lastly, the raising the hands, if you need to, just lower it once you've finished. So with that, thank you very much. I'm going to just share a few things about what's going on in Africa. These are really just very brief comments. As you can see, we're close on to 500,000 cases in Africa, with South Africa being quite the prominent hotspot within the environment of Africa. If you're looking at the trajectory, you can see that that's growing slowly and steadily getting higher and higher. I think if you're looking at South Africa, the profile looks quite alarming, as you can see from these last few months that the trajectory is actually growing. That kink that we saw earlier is clearly not visible any longer. There are quite a few cases, and I think deaths are growing. The deaths are being, this is off the website of the government at 2844, but what's quite remarkable is that these SAMRC pointed out that South African non-natural cause deaths are actually spiking above the norm that has been there historically. And these are just quick snapshots from the SAMRC site that show exactly what's going on. Lots of elderly people dying, much more so than there have been before. I think that's basically just sharing with you a few comments. I want to say, while Bob joins us sharing his slides and the team slides, that we are very grateful once again for Bob and the team from the Western Cape, from Cape Town, to share their ideas, their experiences of what's going on. As within South Africa, the Cape Town area has quite been the initial hotspot. That's shifting slowly to Gauteng and other parts of the country. And so we are very eager, as the rest of the country and perhaps the world and Africa, to see what has been the experience in this space. Bob, are you managing? There are about almost 73 people on the call, and besides the panelists. So I think lots of people are very eager to hear the various voices that Bob, you'll be leading forward. Are you managing with the sharing, Bob?
Yes, I'm going to share just now. Thanks, Shabir. Welcome to everybody. And we've got, I think, 6 very brief presentations that we want to bring to you. And we're going to give each presentation in turn. And then after each presentation, we'll have up 5 to 10 minutes for some discussion and questions. We've got 5 different people who are going to present. The focus is on the Western Cape, but mostly from Cape Town. And I'll introduce the different speakers as we go through. So the 6 topics that we're going to cover, the first one is going to be a little bit on the epidemiology of the epidemic in the Western Cape. Then the second one is going to be on how we've reorganized primary healthcare facilities And then we're going to go into the community and look at what the community health workers have been doing in relationship particularly to home delivery of medication and also to community screening and testing. And then we're going to come back a little bit to look at what's been happening with the other primary care priorities during the epidemic. And then finally, we're going to go to the field hospital, the Hospital of Hope, and hear a little bit about what's been happening there. So I'm going to start off with Professor Hassan Mahomed. I'm going to just share his slides. Let me put them up here. Okay, I hope, can you see the slides? Okay.
Yes, Bob.
Excellent. So Hassan is a public health specialist, particularly working for the Metro Health Services, the City of Cape Town. And he's also a professor in the Department of Global Health at Stellenbosch University. So we're delighted that he's had time to come and join us. And he's actually going to make two presentations this afternoon. And the first one is on the epidemiology of the epidemic. So Hassan, over to you. Thanks.
Thanks very much, Bob. And if you can go to my first slide. Thanks. So I think just to say that I'm presenting this on behalf of a big group of people who've all been involved in managing the COVID epidemic. So I do at the start want to just acknowledge a full team of people from across different academic institutions, health services, and in the community who've been involved in the outbreak. So as at the end of June, we had just under 62,000 cases, and most of them are in the main city in the Western Cape, that's Cape Town. So 3/4 of those cases have been in the main urban area of this particular province. In terms of hospitalizations, of those cases, about 14%, just under 9,000, were hospitalized, and we've had 1,813 deaths, which amounts to a case fatality rate of about 2.9%. And this is about 20% of hospitalizations. This is kind of in line with international trends, and is, of course, a figure that's been going up steadily as we've had more and more cases. The gender distribution, interestingly, is predominantly female, and this is partly because in the early part of our outbreak, it was mainly in essential services like amongst healthcare workers and the retail sector that we had a concentration of cases. And this has led to a female predominance, and this is something interesting that we need to watch further. Next slide. Just in terms of the age distribution of this outbreak, so if you look at the different lines that are there, the blue line represents the population of this area, the Western Cape. The pink line refers to the age distribution of our cases, which you can see is mainly in the sort of 20 to 50 age group, your sort of young adult age group, if you like. And then you see the shifting burden towards hospitalized cases and deaths, moving towards the older age groups. And this is again similar to the epidemic as it occurs globally. Next slide. So how have things changed over time? And as you can see, for the initial period, we had a very steady low amount of cases, and then we've had essentially almost an exponential increase in cases over time. And I think what you see very nicely reflected here is that initially we had mainly imported cases, not very visible there on the slide, and then moving to clusters of cases in various workplaces, and then moving on to local transmission. And we essentially have established local transmission and community transmission, particularly in the metro area of the city. I think one thing to mention is that we changed our testing strategy at the beginning of June, and we are now only testing people who are over the age of 55 or have a comorbidity. And this, of course, also affects our numbers. And what you see from then onwards is an underestimate of cases. Thanks. Next slide. In terms of cumulative incidence, these are the sub-districts within the city, within the metro. And what we see is a variation. So not all our sub-districts are equally affected. And I think for those not familiar with the city, areas like Khayelitsha and Klipfontein represent poorer areas of the city. So the clear picture here is that poorer areas, poorer communities have been more adversely affected by this epidemic. Next slide. In terms of risk factors for death, so acknowledgement here to Mary Ann Davies, who's another public health specialist who's done this analysis. I'm not going to go into too much detail on this, but what we found with our analysis is being male is a risk factor. As you get older, there's a risk, your risk of death increases. Comorbidities such as diabetes, hypertension, kidney disease have been risk factors. And then interestingly, within the South African context, tuberculosis and HIV have also become visible risk factors, not often reported in other countries in the world that have a lower burden of TB and HIV. So that's significant that we've picked this up in our context, and of course represents an important finding for how we manage the epidemic here. Next slide. So I think just to end off this quite short presentation, we had our first case in early March 2020. We had quite rapid growth to 62,000 cases by the end of June. We transitioned from those initial imported cases to clusters to establish community transmission. We had an earlier exponential increases compared to other provinces in South Africa, and that was quite an interesting development that occurred here. And that can be discussed further if people want to ask questions about that. The hospitalization and mortality patterns in line with international experience, but just to emphasize, HIV and TB are particularly important additional comorbidities that we've seen here in an African context, if you like, not that visible in the European, North American, Asian epidemics that have occurred. Last but not least, this epidemic has affected socioeconomically deprived communities more adversely than other communities. And this isn't something very important to just keep in mind, that communities that are poor for various reasons have been affected in a worse way by this epidemic. Thank you.
Great. Thank you very much, Hassan. We're going to have 5 minutes or so now for any questions or comments from others. Shabir, I think you're somewhere there. I think actually with the technology, maybe better if you field the questions. I think you're more familiar with how everything is working on that side.
Not a problem. I can just raise the question that Philly Masopa raises, and I'm not sure it's directed to you, Hassan, but he asked the question, it started with one patient in Mitchell's Plain and one in Khayelitsha. What went wrong? What did we do wrong? Philly's question.
Yeah. So look, it's simply not a matter of what went wrong. And I think one needs to keep in mind that the nature of this disease and the way it spreads is something that's very difficult to control. When we have cases, the fact that we have one case in Khayelitsha and one case in Mitchell's Plain doesn't mean that those are the source cases for other cases in Mitchell's Plain and in Khayelitsha. There are multiple entry points because people who live in those areas work in other places. And as I've mentioned, in the initial phases, we had clusters which were associated with various workplaces. And that essentially is from workplaces to communities where people live is exactly how this epidemic evolved. We followed all the necessary procedures in terms of contact tracing, getting hold of cases, following up their contacts. But again, I think important to emphasize is that we are dependent on people presenting themselves for testing if they are a case. If someone does not come forward and they're ill, we will not be aware of those cases and will not be able to contain the disease. So this makes this disease very challenging to contain. And as we see all around the country and all around the world, despite our best efforts, it does become very difficult. I think, other challenges have been around our testing strategy and our testing capacity. We reached a point where we were unable to keep up with the demands for testing. And what happened is that with delayed test results, it became difficult to do the necessary follow-up or follow-up with cases, and contacts was delayed because results were delayed. And this was a national issue. It wasn't just a local issue. So there are all these practical challenges. At the end of the day, issues such as the lockdown, which was in effect an attempt to try and contain the epidemic, depended really much on people's willingness to adhere and their ability to adhere to lockdown regulations. So, of course, in poorer communities, it's much more difficult to adhere to it. And then, of course, it's people's understanding and willingness to support these lockdown regulations, which affected the degree to which it spread. So there are multiple factors at play in terms of how one.
Why do you think, Hassan, that Western Cape seemed to have led the country in that exponential growth when the entire country was locked down? Very similarly, I mean, that'd be an interesting question. What do you think went differently in the Western Cape?
So I think, the number of factors that that were at play. Firstly, Cape Town is a tourist hub and has a large number of tourists who come in. And in fact, when we examine our imported cases, many of them came from Europe and from North America. And because the city attracts many, we feel that there was a large number of people who entered the country before there was restrictions on travel that seeded cases within the community. And not all of those were detected. There were at that stage no controls or restrictions on people coming into the country. People who arrived could visit and travel as they please within the country. So that was a starting point. Secondly, we had a number of gatherings, or what's referred to as super spreading events. I think if we look at the nature of our outbreak, if we look at things like weddings, funerals, music festivals, we picked up in our contact tracing activities a number of such events which promoted the spread within this area. And then thirdly, even under lockdown conditions, we found that those workplaces that were operating under lockdown conditions, like retail areas, health workers, emergency services, police services, etc., became focuses of infection and spread despite lockdown conditions. So those are three of the factors, and there are many others that I can mention that actually drove the epidemic in the Western.
Thank you, that's very useful. Just to quickly take the one or two last questions, I think we'll have to move on. But, and we can actually take questions again, I'm sure Hassan will do that. Bob, I think, is fixing up the slide sharing, so that should be sorting out. I think Elmer de Vries raises the question on...
People said they couldn't.
Yeah, no, thanks. Elmer asked about comorbidities and the numbers. I think maybe Hassan, you can just point to that, because Ramprakash Kaswa asks the question, we have a high TB and HIV burden, but mortality is higher in diabetes and hypertension. Any thoughts about, the profile of morbidity or comorbidity? Any thoughts about it?
Yes, so I mean, interestingly, that we have, I think perhaps a clinician can address this question maybe a bit better than I can. But of course, we know that all over the world, diabetes, particularly because of its immune suppressive effects, seems to be a higher risk factor, or one of the highest risk factors, particularly uncontrolled diabetes. But additional factors like HIV, of course, which also impairs the immune system, is a factor here. So on the profile that you see here is what we've picked up amongst our deaths. So these are the data that comes from our local experience that predispose to mortality. Thanks.
Oh, great. Thank you very much. Bob, I think you can introduce the next panelists, and I'll take the few questions that are still left to the next or towards the end. We can pick them up again. So Sadiq, we've still got you on record.
Okay, let me just, okay, so I am the next presenter. Let me just find my, my slides. Okay, so I have to try and jiggle all this around. Okay, let me now share these up here, hopefully. They will go. All right, is that working?
Yep, working, Bob.
Okay. Right, so I suppose I should introduce myself. I am Bob Mash. I head up family medicine and primary care at Stellenbosch University. And I have also been assisting the Metro Health Services with the planning around the reorganization of primary health care in Cape Town during the epidemic. So I'm going to share a little bit about what was planned and what has been implemented during this time. And hopefully this will go on to the next one. Are you seeing the next slide?
Not quite. If you just, I can see your mouse moving around. So it should just, you stop sharing.
Changing the slide. Let me see. Here we go. Yeah. Right. Here we go.
Working.
Right. So on this first slide, the left-hand graphic is sort of like the high-level thinking around the care continuum for COVID-19 in the province. And so there was thinking about suppression and containment. There was thinking about the health platform response, and then managing adverse outcomes, as well as recovery and ongoing vigilance. And so I am, of course, now talking about just one component of this entire system, but it's kind of at the heart of it, the primary healthcare facilities. And some of the principles that I think were considered when thinking about how to reorganize care, the first principle, of course, is that actually the majority of cases with COVID-19 are going to be mild and will be either self-managed or managed in primary care. We did, as I say, try to see the interconnectedness of primary health care to the rest of this system, as shown in the graphic. And we also built on a policy decision to develop our primary healthcare services as community-orientated primary care. So 2 or 3 years ago, the Metro Health Services started to reorganize along these lines and to develop both community-based and facility-based services to work in an integrated way that focus on sort of delineated parts of the community. So that was very much an underlying principle that we built on. And then we also, of course, wanted to reduce the risk to people who would have to normally come to the facility. So people particularly with chronic conditions like diabetes, how can we reduce risk for them while maintaining care? We also, of course, wanted to decongest our primary care facilities, both in terms of being able to maintain social distancing, so to have fewer people that we could still maintain an appropriate distance, but also to decongest in order to free up capacity amongst the staff to then manage the surge of patients with COVID-19. It was very important for us that emergency care continued for all conditions. And we also saw this potentially as an opportunity for some innovation and to even introduce things that may be useful once the epidemic has departed. So the first part of our thinking was what we called screening and streaming. And I think this is actually a photograph of Neal David's health center. He's going to be talking a bit later. So what this meant was that every primary care facility had to set up a screening station prior to entry into the facility, where people were screened, obviously, for COVID-19. And one of the things that we've also learned as we've gone along is to try and integrate that screening with screening for other conditions, such as for TB, because there's quite an overlap in terms of the symptoms, and maybe to even introduce screening for diabetes and HIV. Following the screening, then patients are streamed into what we refer to as either a hot stream or a cold stream. The hot stream would be the people that screened positive for COVID-19, and the cold stream, those that screened negative. And then in both streams, there would be a see and treat station. So minor ailments could be seen and treated, and potentially patients could go home without having to go fully into the facility. In the hot stream, the approach was to then assess and triage, and people would be assessed as mild, moderate, severe, or critical. Of course, many of the patients would be mild, and they could then be tested, samples could be collected, minor ailments could be treated, and then a lot of them could be sent home for self-isolation and follow-up. Those that were moderate or severe would be then admitted into the facility in this separate stream and would receive treatment such as oxygen and so on, and would most likely be referred. We took the decision that we would not recommend any intubation or ventilation in primary care. Most of the facilities have at least one ventilator, especially in the larger 24-hour facilities, and that was kept more on the cold side. There was also a recognition of the possibility that critically ill patients might be admitted to primary care facilities, and that it might actually be better for them and for the system to provide end-of-life care within the primary care facility in some cases, rather than trying to send them on. And then, of course, the other thing was that to provide the other primary care services that they might need within the hot stream, rather than having to then send them across to the cold stream to get other services that they needed. In the cold stream, acute medical problems or acute problems were admitted to the emergency room or center and treated as normal. I think one of the things that we learned about the cold stream is that it's actually also not safe. So because of the large number of asymptomatic or pre-symptomatic patients, it's perfectly possible to get infected even when you're in the cold stream. And so it's important to still maintain PPE and precautions in the cold stream. One of the groups that we particularly de-escalated and shifted as much as we could from the facility into the community were those with these comorbidities. So that's the people with diabetes and hypertension, HIV and TB, mental health issues. So trying to get a lot more of the follow-up being done by the community health workers in the community to keep these people out of the facilities and at less risk of infection. A lot of the services did continue. So maternity care continued, family planning continued, immunizations and growth monitoring continued. And Hassan will tell us a little bit later about what happened to some of those services. A lot of the support services were either stopped or significantly reduced. So things like the therapies, rehabilitation, eye health, oral health, nutrition, counseling, and a lot of the social work services were either stopped or offering telephonic support. One of the things that we did was we adapted the NICD checklist to check the readiness of primary care facilities. We adapted it to align with our plan and to also look at a lot of the necessary inputs around infrastructure, supply chain, health information, people management, and so on. And so we've got all of the facilities to fill out the checklist and tell us their readiness. And you can see here that I think there was around 43 different items that they were asked to report on in different areas. And overall, the readiness, I think this was probably by sort of end of April, beginning of May, the overall readiness was pretty good. However, some of the key issues that were identified in the readiness checklist, first one was infrastructure. So in Cape Town, of course, we have now the onset of winter. And I think you saw from the earlier photograph, a nice sunny day with people being screened and streamed in the car park, which of course is no longer possible when it's cold and wet. So quite a lot of the facilities required additional prefabricated units to be installed to maintain the two streams. We also had a lot of issues to deal with around people management. So a lot of stress and anxiety when staff members would become infected, people refusing to work in certain areas, people wanting the facility to close for cleaning. So a lot of issues around information, testing, and support to the staff. Social services, I think, was another area where the link between health and social services was problematic. We've seen very few referrals from community health workers to social services, and many of the facilities reported that they were not sure how to access social services during this time. Facilities also reported that they were not sure how they would actually deal with a massive surge of patients if that was to happen, and that needed additional planning. And then there were some issues, I think, in some facilities with setting up appropriate committees and management structures. And then I think the final issue has been around the ability of the ambulance services, the emergency medical services, to transfer patients. So a lot of the facilities have been reporting that patients with who needed hospitalization have been sitting in facilities for, even until the next day, and sitting there for something like 12 hours waiting on the ambulance transfer. So that has also been an issue. Yeah, I think that is my story on the reorganization of primary healthcare.
Well, thank you very much, Bob. That was very useful. Just some questions that people asked. I have one or two myself. You've talked about, the way in which you'll manage your hot stream and cold stream. And a question that Michelle asks is how much oxygen is needed at clinic level? And I think the whole question of your clinical management in that hot stream, whether you have pulse oximeters there, is there a way in which you manage with oxygen for either managing in the space or referring on where you're waiting for hours with EMS, not coming along? So is there any clarity you can provide on that clinical management?
I think others can comment.
Sure.
Maybe Neal can also comment, but I think all of the facilities have oxygen. Okay. I think pretty much all of the facilities have pulse oximeters. So it's perfectly possible to provide oxygen therapy in primary care and to monitor oxygenation. But as I say, we decided not to go as far as intubating and ventilating people in the primary care facilities. Neal, do you want to comment on that?
Yeah. If you have some idea of the kind of burden of care that's landing up on primary care clinics versus CHCs, sort of out of your patient numbers, what sort of numbers are you seeing pitching up there? Because this demand management would be very helpful for primary care. Neal?
Yeah, sure.
Just share.
Yeah, sure. The demand varies a lot from day to day. I mean, we get busy days and we have days where it's more manageable, but we very rarely have run out of oxygen. There have been days where it seems as if we are about to run out of oxygen, but we generally find oxygen to supply to the patients. Our hot stream is in a student learning center that we've converted into the hot stream for the time being. So our oxygen is via oxygen cylinders. We don't have piped oxygen in that area. So far, thankfully, we've been able to manage. And of course, we do go according to the patient's clinical status and,
of course.
And
just
situation.
Just giving people elsewhere. I mean, are we looking at you use one tank, once a day for a fairly busy clinic? If you're looking at, let's say, a sort of hot stream area dealing with about 20 patients. I'm just trying to get an idea, something that you give another person another sense of what changed. I mean, I give you an example. In one of the CHCs, we're seeing headcounts of usually about 1,000. Now it's down to about 600. Out of that, we're now seeing, at the moment, we're seeing about 20. Over the last 2 weeks, it's gone up a bit more to 30 and 40. And we haven't yet had that sick patients, badly sick. But where are you now where you kind of can share what your volumes look like and what sort of needs we need to warn people about that, listen, it'll go quite high. You just give an idea of that sort of,
okay.
Just a quick thumbs up. It doesn't need to be very scientific.
Okay. The point is really, the question I think relates to how many of our patients that come through the COVID zone, which could be a lot. I mean, it could be up to 100 patients that go through the COVID zone on a daily basis. But
that's in a CHC.
But of course, not all of them will need oxygen. That's really the issue. I would say probably 1 in 5 patients need to be on oxygen for prolonged periods of time, waiting EMS transfer.
No, sounds good. So if you're looking at your numbers, you've seen 100 now. What sort of numbers were you seeing, let's say, 2 months back? If when you started, what sort of numbers were you seeing right at the beginning when you set up the zone, the streams?
Fairly small numbers back then, because well, of course, we hadn't quite achieved the streaming 2 months back. So
when it started coming together.
What our stream is in effect a respiratory stream. So we're diverting everybody with respiratory symptoms into the hot stream, whether it's an upper respiratory tract infection or bronchospasm or any form of respiratory symptom goes into the hot stream and then gets differentiated. So in terms of patients who were COVID suspects 2 months ago, I would say the numbers were relatively small. If they're 100 now, they were probably 20 back then.
Good. I think that's the proportion, because I think that's what we need to realize. Oh shit, we're going to see 100 now from 20. I think it'll give a wake-up call to a lot of people. And at least what you've just said, 20 need no oxygen. I mean, it might be spread over the day, but helps to understand. Good, thanks, Neal.
Aspect I think that you'll see, and Hassan's going to say a little bit about this later, is that the total primary healthcare headcount has plummeted.
Yes.
So there's a lot of people who are not coming for other reasons.
Yeah. And I think just to add some comments, and then we can move on to the next one. I think there's a comment from someone from Delft about ordered 2 additional 10-liter oxygen cylinders. The people in the group can see it. I think Mosedi talks about hot and cold area in emergency units. I imagine that's in sort of district level hospitals. And I think that the other question, maybe you can respond to, Bob, is have there been a large, this is anonymous, I think from Mumbai, perhaps in India, I think that's talking about community health workers being deployed. I mean, have they been deployed in numbers to educate on preventive measures? What's the nature of the deployment in the community?
The community health workers.
That's right. How are they being used?
So I think the next two presentations are going to say a bit more about the community health work. But we've got about 2,500 of them, and we've employed more during the epidemic. Yeah, I think maybe I'll leave it to the next two presenters to tell us a bit more. Yeah.
Good. No, that's a good segue into the next presenter. If you can just introduce next, and then we'll take it from there.
Yes.
We'll
so
pick
the
up
next
the questions later.
is Zameer Bray. And Zameer is a medical doctor. I think he graduated from University of Cape Town, if I'm not mistaken. And he's currently working for the Bill and Melinda Gates Foundation. And he seems to be working a lot though with the Metro Health Services. So I'm not quite sure how that works, but I think there's quite a strong link between the two. He's been instrumental in the setting up of home delivery of medication. And so he's going to tell us a little bit more about that. And I'm going to try and share the slides. Let me try and do that.
Sure, thanks, Bob. Thanks for the introduction, and thanks to the organizers for the opportunity to present some of this work. And also just an acknowledgement to all the provincial folks that actually have made this really innovative project possible, particularly the community healthcare workers that quite literally give this project feet and legs. Bob, we can probably go into the next slide. So I think maybe just to take a second and reflect on why home deliveries were so important at this particular juncture is we've just heard Hassan kind of outline that some of the risk groups, some of the individuals at most risk from COVID disease and death are in fact those that are on chronic medication like diabetes, hypertension, HIV and tuberculosis. And so at an individual level, the idea was to protect those individuals from COVID. We've also known that during the lockdown period, accessing facilities was a challenge. HSRC survey sampled about 20,000 people during the lockdown period and found that 20%, about 1 in 5 in settlements, actually could not access their medication at a state facility. And then also the need to continuously, the second two objectives are around a longer term objective of decongesting facilities and giving a community orientated care model kind of more tangible mechanisms. We can move on to the next slide. And I guess underlining all our efforts was really to try and find an approach that focused on the patient and figuring out how the system could respond to that. Bob, can we move on to the next slide? Yeah. So just to reiterate, and just putting it in a different kind of graphical form, what I touched on earlier is the experience of the Western Cape and really excellent work done by Mary Ann and the team in identifying what are those risk groups that are most at risk of death. And one can see diabetes and HIV showing up very strongly, as well as hypertension and TB. I think it is worth pointing out and to respond to a previous question around, is there differential risk based on previous glycemic control? And the answer is yes, in fact, quite strongly so. And when one looks at the hazard ratios, those range from 5 to above 12. Depending on individuals' glucose control before having COVID. But there is also evidence that, in fact, short-term glycemic control may have an impact on severe disease and mortality. Next slide. So I think this is really the kind of how does it work? You know, I think we were kind of sitting around talking about the problem, and Dr. Perez, the chief director for Metro, walked in and he said, we've got to get patients their medication. You guys have 3 days to solve for this problem, go and figure it out. And that was actually a fantastic mandate to innovate around what the existing system was. So what I want to show here is that the medications were pre-packed. And in fact, many parts of the country in South Africa, this is happening. The medications are pre-packed and they delivered to facilities or another community pickup point. But in the Western Cape, they were mostly delivered to facilities, and individuals had to come to facilities to collect their medication. Now, clearly that was suboptimal during this period, both at an individual level in the risk exposure, but also at a running the risk of becoming, super spreaders through using public transport, etc., etc. So the relatively simple problem we were solving for is how does one connect facilities over here to a community healthcare worker points. And these were where community healthcare workers were actually kind of meeting and congregating in the morning to start their day. Bobby, if you click once, something should happen on the slide. There we go. And so what we started off was with a model where Uber basically linked and just served as a connector between facilities, existing facilities, and community healthcare worker nodes out in the community. And what was profound about this is that the magic of community healthcare worker networks, and as Bob mentioned, 2,500 healthcare workers would carry between 3 and 5 patients' medications each per day, gave us the ability to reach 10 to 12,000 homes every day. Some of the innovation that happened around this was initially, while we started with Uber, it was great to see that in fact there was some spare capacity with government vehicles. Some of the NPOs and NGOs started using their own drivers to connect facilities and community healthcare worker networks. And there was the ongoing project that actually used bicycles to deliver to individuals' homes. Next slide, Bob. So the project in Cape Town has reached a really strong level of maturity, and I think credit should go to the program management team, the community healthcare workers, and the NGOs that support the program here. I really kind of feel like it's gone beyond the pilot stage, and I'll show some of the numbers that demonstrate that quite clearly. But it's also encouraging to hear that colleagues in Tshwane, University of Pretoria, have launched a pilot where they are actually adding a telehealth service on top of the medication delivery. And I think that the service is going to be expanded, I just heard earlier, to a couple of other spots in Gauteng. And they are actually able to offer individuals a kind of a teleconsult service and then plus the home delivery. In eThekwini, there's also some additional, so this is started in 7 facilities in eThekwini and possibly in Buffalo City soon, where they are also offering the option of a pop-up kind of setup outside a mall where individuals can actually come, collect the medication and then leave. And those are literally, pop-up kind of setups. Next slide, Bob. So just to give you a sense of the quantum of deliveries, so daily in Cape Town, in the metro, about 5,000 patients receive their medications. Since the start of the project, almost about 250,000 patients have received the medications to date. This is just a little article where the Premier visited these sites. One can tell that this is a project kind of launching into quite a big scale effort. Next slide, Bob. I think we can skip this one and maybe just end on the last slide, Bob, which is, I think a kind of an important metric that we should all hold ourselves accountable to. Is this making a difference in the lives of patients? Lots of feedback on social media. We're just looking at actually some handwritten notes that were sent from patients that received their medications delivered to their homes. And I think very importantly, escalating and elevating the role and value contribution of community healthcare workers in the ecosystem in a very tangible way. Thank you.
No, thank you for that, Zameer. I think really useful project. I think that's kind of responded to some of the questions that people have asked, which is, how have there been innovations in using community health workers in the Western Cape? I think you've described some of the comments about, is it just limited to community education and screening and testing? And clearly it's much more wider than that. Zameer, are you on the call?
Sure. I mean, I can respond to that briefly, but I'm sure there's others that may want to weigh in. Shabir, I think that what it has done is it's created an interface, and community members and patients have really appreciated the role of community healthcare workers, and it's created an opportunity for an engagement and an education opportunity. So as the packet of pills gets handed over, you know, just a brief check-in about your symptoms, are you feeling okay, both for COVID and for, you know, whatever packet of pills are being handed over.
For sure. You know, you've mentioned that this has worked seemingly ahead of other centers that you've experienced with. Why has it worked quicker, better? You know, when I looked at it, things that I heard were, you know, the CHWs being very integrated from what Bob said, that you'll have actually been very, very innovative, including the private sector. I heard you mentioning Uber. This seems quite different. Why is it working in the Western Cape where it might not be elsewhere?
I mean, I think that we kind of, as outside of the system, you know, being with the Gates Foundation and looking in and kind of supporting this, one really has to acknowledge the leadership and the program management that actually saw this as an exceptional opportunity to build a system for a beyond COVID era. So I think that that kind of leadership covered to do this work is probably a key catalyst. In terms of private sector, it's been interesting because I think Uber, during the lockdown period, realized that they had so much latent capacity and they wanted to help in some way. And so what this project gave them was a very concrete way to do that. And in fact, what it sprouted for Uber is a whole series of business models around other additional service offerings. So can Uber, for example, be used to bridge the gap between mothers that need to attend antenatal services? Because we've seen a 30–40% reduction in antenatal visits. You know, so can you offer a free Uber ride to the mother that's got a clinic card going to for her ultrasound scan? Madagascar's done it. You know, surely we can. And so I think that one of the key kind of takeaways here is that while we need to focus on COVID, is what's the opportunity within the complexity and chaos that COVID has brought that allows us to innovate for the routine health service delivery beyond this.
No, that's great. I think just a comment came from Anonymous. He clearly is disgruntled. He says, lots of extra work from facility-based staff because lots of stuff is getting returned because patients are not giving right addresses and the information is not being updated. So some people on the ground kind of contesting it. But I think that Tato Mosidi raises the question of, you know, can we not look at integration of programs, TB, you know, HIV, mother and child, like you've just raised now. I think we'll come back to the question of the impact generally on other services later. So with that, I think, Bob, we'll go on to the next question. Next presenter. Thank you, Zameer.
Thanks. Yeah, just to end up with that, I think we're successfully delivering about 70% of the parcels. And there is a problem with having people's correct addresses. And one of the strategies to address that has been to create a WhatsApp bot that has been sent out to the public in Cape Town so that they can actually register their correct address. But it is an issue.
That sounds really neat. Very good.
I would like to introduce Neal David. You've already heard him speak. So Neal is a family physician and he works at Hanover Park, which is one of the community health centers in Cape Town. And he's also been assisting the Metro Health Services at a sort of a higher level with a lot of the sort of clinical thinking around primary care. So thank you, Neal, and you're going to speak about the community screening and testing, which is one of the projects that you've been heading up. Let me find your slides. Okay, hang on, let me get back to the beginning. Okay, and share these. All right, are you seeing them?
Yes, thank you. Thanks very much, Bob.
Okay.
Thanks. Well, not that one. Thanks, Bob. Thanks for the opportunity to just give a very brief thumbnail sketch of the community screening and testing program that we initiated in Cape Town. If you can go to the first slide, Bob. Okay, so this was initiated in early April in accordance with the presidential mandate and the National Department of Health Directive to do community screening. The aim was to identify community members with mild symptoms who weren't self-presenting, according to the NICD case definition at that stage, in a sort of case-finding approach, and to limit the onward transmission as far as possible, flattening the curve, as it was referred to, with identification of cases in the community, as well as contact tracing and isolation and quarantine. So approximately 2,000 community health workers that were employed by NPOs, that are employed by NPOs in partnership with the Western Cape Department, and a few hundred more externally funded community health workers were deployed within the 4 substructures within the metro to perform household screening for COVID-19. And then testing sites were set up in communities supported by the substructure offices and local primary healthcare facilities to take nasopharyngeal swabs from the individuals who were directed to the testing sites by the community health workers. And this photograph was taken in the Blackheath community screening and testing site on the day that we launched the program, which was the 4th of April. It was a Saturday. And you can see the various components from the doctor supporting the screening of the testing process, from Khayelitsha Hospital to the various nurses, to some of the NPO staff, law enforcement. So it kind of captures the essence of what a testing site looked like. Can we go on to the next slide, please, Bob? So essentially a community-orientated primary care approach was used to develop the community screening and testing program. And COPC essentially identifies healthcare challenges in demarcated areas and develops appropriate primary healthcare strategies to address the issue, and focusing a lot on community engagement. And so here are examples of some early maps which we use to identify the location of cases in communities. These 2 maps are of 2 different substructures, the top one being the southern substructure. And what you can see are the blue dots being the imported cases, which predominated initially, and then the pink dots being locally transmitted cases. So as the first map suggests, the imported cases initially predominated in the CBD and the Atlantic seaboard, as Hassan has already alluded to, a lot of returning travelers and also tourists, but these cases were rapidly overtaken by local cases. And then in the poorer areas of Cape Town, almost all diagnosed cases were locally transmitted without any previous contact with an imported case. Can you go on to the next slide? Thanks, Bob. So the approach that we adopted specifically in Cape Town was a targeted approach to community screening and testing within the hotspot areas as a containment strategy for the metro. So hotspot areas were identified based on locations where known cases and persons under investigation were identified, and particularly within areas that had high socioeconomic vulnerability. This was also part of the National Department of Health mandate to really focus on areas with what are called a high social vulnerability index. And in this photograph, you can see what we call a large polygon in the Delft South area. And then within that area, we would isolate what we call the numerator areas, consisting of 200 to 250 households within the vicinity of a known case. And the plan on a daily basis was to screen each household, going door to door, teams of community health workers going door to door within that enumerator area, and screening for anyone with symptoms according to the case definition, and then referring to the testing site. So the aim of the program really was to identify cases in vulnerable communities, particularly where people would struggle to self-isolate. And in this way, we did manage to identify early clusters in communities. These were identified, and affected patients were offered the option of assisted isolation if they were unable to self-isolate. One of the first facilities that was used as a quarantine and isolation facility was the Lagoon Beach Hotel in Bloberg, and then others were subsequently brought on board. So I've used this date of the 11th of May, at which time we'd screened 123,000, over 123,000 people in these communities in this way. And we'd performed over 12,000 tests, and we had 523 positive results, which represents a positivity rate of 4.24%. Although, as a few subsequent slides will demonstrate, this is probably an underestimation of our positivity rate, because of issues that accrued subsequently. So up until this point, I think it was relatively safe to say that we had contributed to a process of flattening the curve. But the subsequent half of the story, if you like, can't be evaluated as positively. So really, up to this point, community screening and testing combined issues of prevalence, social vulnerability, and community engagement to achieve its objectives. On the left-hand side of the screen is the kind of community notice that would be published weekly and on a daily basis, informing communities where CST sites would be set up, where to expect community health workers in the community. On the left-hand side of that form is the all the metro sites, and the rural sites were also listed on these notices. And this specific notice was for the week of the 11th to the 15th of May, where really everything turned around, as I'll come to. The map on the right represents, sorry, can we just go back to the map, Bob? The map on the right really represents a compilation of our activity, showing cases in the communities overlaid with areas of high social vulnerability, and showing how essentially our activities were concentrated in the Cape Flats area of the metro, with some additional activity taking place in other high SVI areas, such as Masiphumelele down in the Notuk area and in Dunoon north of Milnerton. If you can have the next slide, thanks, Bob. So towards the end of April, which was essentially only a few weeks into the program, myself and Bob co-authored a short report on CST, which was subsequently published. But even at that stage, with a few weeks of frenetic CST activity behind us, we could see a few sort of ominous storm clouds building up on the horizon. And we identified two major risks to the CST program. And we wrote in the report, going forward, heightened security measures would be needed from private security companies or even the army. Provision of relief packages to poor communities on humanitarian grounds could mitigate the deteriorating security conditions. And this is what our CST teams in the communities were up against. We were focused on the areas of high social vulnerability, and it was precisely in these areas where food security was becoming a problem as income was drying up, and our teams were often at risk of harm. They witnessed looting of shops and food trucks. They were on occasion the victims of crime, and on one occasion at least they were caught in some crossfire between law enforcement and gangs in the area. So that was one of the issues. The other significant threat to the CST strategy is the increasing turnaround time for test results, as laboratories were overwhelmed, particularly our NHLS lab. And if cases and contacts cannot be identified quickly, then screening and testing becomes ineffective. Can we go on to the next slide? So here we see a specimen that was collected on the 11th of May at a community screening and testing site in Khayelitsha. And as you can see, it was collected on the 11th of May, and it was reported on the 6th of June, which really represents a reporting time which adds no value at all to any kind of screening and testing program. But just to contextualize this issue, as CST was proceeding, primary healthcare facilities and hospitals were all generating large volumes of tests on patients and healthcare workers who were clinically less stable and who were rightly so given priority. The NHLS was running out of capacity to test specimens and unable to replace material that they'd used because of global competition. And obviously the turnaround time was becoming completely unsustainably long. What we did know was that widespread community transmission had become established anyway, and these tests were adding no value to our containment efforts. And so under the guidance of Hassan and David Pienaar and our public health colleagues, we really, in that turning point week, we conceptualized a new strategy relating to community screening and testing, where our existing CST program was completely scaled back, and we came up with criteria which would be more helpful in terms of who is tested in our system. And we have turned around the testing situation to the extent where we now have additional lab capacity, although I suspect that is also because of assistance that was provided to us by National Department, and any additional capacity we have might have to be diverted to other provinces from now on. But the new strategy that we've incorporated has really highlighted the COPC elements that Zameer has talked about, and that we're really very proud of. I mean, in fact, it's really the way we were able to leverage COPC that allowed us to do well in the first part of the CST program. But now we're focused on the high risk population and at mitigating against poor outcomes. So thank you very much.
Well, thank you very much, Neal. Really useful insights on a program. I think it's something that's become a thorn in everybody's flesh about whether that's worked or not. I think Anonymous also complained about the same thing, you know, that it seems to have been a waste of time and misdirected in terms of resources. I think a question that Michelle asks earlier is about, and she asks a question firstly about, have you thought about families in terms of quarantine? How does that work, you know, in terms of reaching out there, testing, and then what's the implications of people and support for, let's say, children, where they, you know, how services work? Is it a very integrated process? Perhaps you could just respond to that, Neal.
Well, at the moment, we are promoting isolation and quarantine facilities very actively. In fact, we are only using about 25 to 30% of our existing Q&I capacity within the Cape Metro. And we're encouraging people with, so we've got two different streams. We have isolation facilities for patients who have known positive results. And then we have quarantine facilities for patients who don't have a positive result. Isolation facilities tend to be group facilities in which patients with positive results can be grouped together and wait out the isolation period. But our quarantine facilities are also fairly available at the moment, and we've got a lot of facilities that are literally waiting for patients to be sent in from our facilities. But there are reasons why patients haven't taken those up. But safe to say that the facilities are available.
Yeah. And is there any stigma in the community? Michelle asked that same question around, is the messaging and the relationship actually dealing with stigma? And are we getting, instead of, and some people may actually not come to the clinic. And so, in terms of getting out there in the community, and then also the problem might be that you have too many people coming to the clinic because they're all anxious. What's the dynamic there?
Yeah. Look, the new strategy is really very, very much built on a foundation of education, engagement with the community, relating to behavior change strategies. It's not easy, but the more we educate each other, in fact, about the way we all have to behave, going forward, the easier it will be to achieve a kind of a unified approach, and a reduction in stigma, in fact. The reduction in stigma is surely based on the idea that there is no particular group, there's no particular individual that's at risk, that we are just linked by we're one human chain, and we're all links in that chain. And I think that's what our community health workers are trying to achieve, particularly in this new strategy, which is not really about testing so much, but about achieving behavior change and identifying high risk.
And so, if I may just close with this comment that that the community health worker program is very strongly integrated with the clinical team at the clinic, with a very strong relationship in terms of responding to community hotspots? Or do you think it's more of a program that's being driven by the province with very little integration with the local clinic? I think one of the comments by Anonymous was that is actually the problem, that the CST was very disjointed.
Look, I think the aim of the COPC approach is to achieve an integration, that a level of integration that, in all honesty, we don't have at this point. What I can say is that the innovations around COPC that have taken place during the pandemic have really leapfrogged a lot of barriers that we still had to overcome, pre-pandemic. And I mean, I'm hoping in the post-pandemic era that the community-orientated primary care approach will be a lot more integrated with primary health care as a whole.
Oh, great. Thank you very much, Neal. Over to you, Bob, to introduce our next speaker. Just in terms of dealing with questions, we'll see if there's enough time. We've got up to the half hour to half past, and then we'll see if we can manage. Otherwise, we'll try and answer the questions before.
Maybe what I will suggest is we'll do the next two presentations back to back, and then we'll have a final round.
Let's do that. I think that's better.
So I don't need to introduce Hassan. It's Hassan again. I introduced him earlier. And so welcome back. And Hassan is going to talk a little bit about what's happened with the other primary care conditions during the pandemic. Yeah, thanks, Hassan.
Thanks, Bob. You can take the next slide. I'm going to be building on what my colleagues have already mentioned, and what I'm mainly going to show is just data that illustrates points that they've already made. So I'll keep my presentation fairly short. So just to mention, there was an intentional de-escalation of services because we were preparing for a surge in service pressures from COVID-19. Both at the hospital and the primary care level, and then with a specific focus on chronic stable patients. And of course, we did put in place plans to try and manage this situation and focus on various areas. Next slide. This slide shows the metro and rural headcount, and you'll see from with the April data that there was quite a steep drop in headcount, and similarly in the May data, which is not shown here, there was also quite a steep drop in headcount, but worse in the metro compared to the rural areas. And the reason for that is that the epidemic was worse in the metro area than in the rural areas. Next slide. If one looks at the impact on TB, so this is the number of patients starting TB treatment, and you'll see for both April and May data that numbers dropped dramatically compared to previous years. So you'll see several years of data, 4 years of data here, and showing the first 5 months of the year. And again, we see a steep drop, and it's worse in the metro compared to the rural areas of the province. Next slide. Interestingly, in terms of diarrhea, you'll see that the number of reported diarrhea cases at PHC, if you look at that purple line on the left, you'll see quite a steep drop compared to the previous 3 years in the number of primary healthcare diarrhea cases reported. And on the right-hand side, you'll see a similar drop in diarrhea admissions. So this is an interesting phenomenon. If you think that a drop in PHC diarrhea cases might lead to more admissions rather than less admissions, we paradoxically saw actually lower admissions. Does this mean that there was poor access both to primary care and to hospital level care? Possibly so. In terms of deaths due to diarrhea, there's no obvious increase in deaths in this particular group. So this becomes a bit of a conundrum to interpret. One of the suggestions, in fact, made by Bob is that possibly the lockdown that we had over this period helped to reduce transmission for diarrhea as well as for COVID. So in fact, you know, a sort of a collateral and positive effect on our cases. But nevertheless, you know, this is something that that just needs to be watched carefully. Next slide. So I think just in summary, I see one slide got missed out, which was the one I had on HIV, which similarly also showed a drop in retention of care. So in summary, our headcounts have dropped quite dramatically for the April-May period during lockdown. Missed appointments were due to lockdown, lack of transport, social distancing, stay-at-home messaging. So a number of factors related to the COVID epidemic and the fact that people had to stay at home affected attendance at our facilities. We de-escalated our services, and this reduced the opportunities for screening and testing, much of which happened at sites where people gather, like our facilities, but also at community centers. The impact was more evident in the metro area than in the rural area. And again, as I explained, the epidemic was much worse in the metro and affected people much more than in rural areas. Immunization rates dropped as well. And this is of particular concern as we would be concerned about the potential for outbreaks. So over the last 2 months, the immunizations also dropped, and that's obviously would be of concern, and that's something that we need to pay attention to. So inadequate screening, testing, treatment initiation for TB may lead to an upsurge in TB cases. So we need to be wary of this, and we need to look at how we can rescue the situation. And similarly, lower retention in care may result in increased morbidity and mortality from this particular disease. So there's been quite a substantial negative effect on health services, on attendances. There have been attempts to try and manage this, but it's been difficult because of lockdown conditions. I think as Zameer showed very nicely, you know, the delivery system for chronic medication was one way to try and limit the impact on chronic diseases of lifestyle, as well as diseases like HIV, where even the clubs couldn't meet because one wanted to avoid gatherings of any kind. So there's been a definite negative effect. So these issues have been discussed in depth over recent weeks by the health department, and they are putting in place plans to try and address the deficiencies that have occurred. Thank you.
Great, thanks, Hassan. I'm going to now go straight to the last presentation, then we'll have questions for both. So let me introduce the last speaker. It's Klaus van Preston, who you can now see. Klaus is also a family physician, and you can hear me, right? I think I unmuted myself. Yeah.
Yes, we can hear you. And
Klaus was recently appointed as the head of family medicine at the University of Cape Town. And as he arrived to take up his new academic position, we de-routed him to the CTICC, the International Conference Center, and asked him to clinically take the leadership of the field hospital there, the Hospital of Hope. And so he has been helping to run that facility now for the last few weeks. And so we've asked him to also just say a little bit about what's been happening there. And I'm going to find your slides, Klaus. Let me put them up here. Okay, are you there? Thanks, over to you.
Thank you, Bob. Thank you, Shabir. Thank you, everyone, for the chance to join this very engaging conversation. So as Bob has mentioned, I've had the pleasure of joining the COVID-19 field hospital in Cape Town, which was coined the Hospital of Hope. And I need to acknowledge all my colleagues, both at the CTICC and the Metro Health Services, as well as my colleagues at the Family Medicine Division at UCT, as well as UCT Management, because they, in a sense, they gave us this opportunity to join this very exciting project. If you can go to the next slide. So the CTICC, as you can see on the top left, is normally known as the International Convention Center, where you can see the big four halls where often over weekends there's a number of events ranging from from all types of events that they put in there. And when this COVID pandemic started to happen in South Africa, the Western Cape Government Health realized that they had to extend the acute inpatient bed capacity of the Western Cape. And they've, through their disaster management response, they've identified a number of facilities to repurpose as alternative care sites, or as they called it, intermediate care bed facilities, or field hospitals, if you like. So a large part of the process was the commissioning phase, and then from the commissioning phase, making it operational. So one can just imagine that you're basically making a hospital in a space that was not normally used for inpatient care facility. And the reference down below, the New England Journal of Medicine, describes some of the ways that these alternative care sites have been used across the globe. Their article focused mainly on the US and UK experience. So we've also now joined that experience of having to repurpose these facilities. The CTICC has been repurposed as an 862-bed field hospital since the beginning of March, and we had our first patients admitted from Monday the 8th of June, after the president has officially opened the facility. The next slide, please. So as you can imagine, a large part, I mean, the one part is of this commissioning phase is to create the infrastructure, to put in the beds, to get all the oxygen piping up. So all these 862 beds have the capability to deliver 15 liters per minute of oxygen. But it's the other interesting part for me, and I think for Taslim and other colleagues who are keen around learning, and especially also Steve Reed, a professor from the Primary Healthcare Directorate, and also a family physician, joined us together with Ronald Akun and our consultant team, which consists largely of family physicians, as well as emergency medicine physicians and internal medicine colleagues. And together with the facility operational management, we've gone through the whole process of the PDSA, as also from the Institute of Healthcare Improvement. And we had to organize ourselves also as a team, both management and clinical, to decide what is it that we want to deliver for the span of the project, which we don't know if it will be 2-3 months. And also so trying to suss out what would be the benefit to our colleagues across the platform. So we went through this process and then generated this overall aim for the hospital. So our aim is to offer hope from the Hospital of Hope by delivering high quality, efficient inpatient care in response to the needs in a Cape Town metropole, whilst ensuring the safety and positive growth of staff. That was very important. So we wanted to have that alignment and that aim to sort of inform all our activities. And I think that this need to be responsive to the needs was quite core to our purpose, as well as balancing patient safety and efficient care with safety and learning growth of our staff. The next slide, please. So as part of having these learning conversations, we've set up the schedule of activities throughout the week. So it's not just all about learning and working in offsite. It's especially also making sure that there is a cohesion for the team in the hot space. So we've got quite a dynamic team from the diverse background, which also includes Cuban colleagues. So each day starts off with the clinical team having their morning huddle, and the operational management team also meeting together on some days of the week, as well as having a combined learning meeting on Fridays. Late morning, we then have on a clinical side on the floor a visiting consultant from our referral hospital colleagues, and then also another part would be a daily bed management huddle, where clinical managers from across the acute hospitals in Cape Town Metropole link together for half an hour, just so we keep our tabs on where the pressures are on the acute beds, because we want to be responsive to the needs and alleviate those pressures experienced by our counterparts. And then at 1 o'clock daily, we have a learning meeting either with the clinical team leaders or the consultants. And on Tuesdays and Thursdays, we involve the multidisciplinary team through an allied health focus, as well as an M&M meeting. The next slide, please. And so roughly a month now after we've started this process, we've come to a point of reflection, and we can probably say that, I mean, we've been using the electronic referral platform Vula. We've had about 850 referrals to our facility, of which around 650 patients have been admitted. Especially during the last week or so, the daily intake has been around 40 to 50 patients. And we're at the moment standing about at around 300 beds. So we haven't quite reached the full capacity of the facility. But I think for me, this quote from one of the team leaders, Dr. Nabila Amin, who's also a senior family medicine registrar at UCT, just epitomizes some of the qualitative reflections from the team. She shared this, and it's also been shared through the UCT Faculty of Health Sciences communication team, as that the biggest success that this team had is that from starting from something from scratch and managing to keep it running successfully with incredibly high standards of care. COVID-19 is a disease that can bring about anxiety and fear, even in the strongest minded clinicians, if the CTICC Hospital of Hope patients are still treated with compassion and respect. The amount of passion I've seen from the staff is absolutely incredible. So I think that was the final slide. So I think for me and having had this chance to be part of this event, this activity and project so far has been really rewarding. Like you say, it has been probably not quite what everyone has expected. I mean, this whole pandemic has changed everyone's short-term plans, but I think with a medium-term focus, it has really been valuable in terms of building networks, getting to know colleagues across the acute services platform, and feeling that we are able to contribute. So thank you very much.
Thanks, Klaus.
Thank you, Klaus.
Yeah.
Yes, thanks, Bob. Thank you very much, Klaus. I think that, it's amazing stuff that you guys have been doing. And one thought that crossed my mind is both the innovation that you're able to all achieve. The context seems clearly much more empowering, much more enabling than I think many parts of the rest of the country feel. So I think just in terms of questions, Anonymous, makes a mention about, I'm not sure they're all the same Anonymous, by the way. So you must be fair to whoever's Anonymous out there. Is that there's a strict criteria apparently between for admission to CTICC and a disconnect between CTICC, referral hospital, and Q&I. That's quarantine and in isolation sites. Would you mind sharing a bit of what exactly are the ways in which you'll have organized yourself? And then we'll get to Hassan and other questions as well. Klaus.
Thank you. So that's a good question. I mean, originally the facility was conceptualized to only admit patients who are fairly mobile and have perhaps oxygen needs. But I think through these learning conversations and in conjunction with our colleagues from across the acute service platform, we have been able to redefine our admission criteria. So we essentially have 3 types of patients, if you want to classify them as such. So the first type would be people mainly with a COVID-19 diagnosis of moderate disease who have oxygen needs. Then the largest group, around 60–70% of our patients, are patients actually who have COVID, but their whole disease profile has been complicated through their comorbidities, the diabetes especially, other comorbidities, COPD, lung disease, chronic heart disease. And then also about 20% is a group of patients who are less mobile, who are for palliative care. So within this first few weeks, we've become really, in a way, reoriented to be responsive, but also have pockets of excellence and pockets of specialization of care, both from the nursing side as well as from the clinical team. For instance, the one family physician leads the palliative care side, and she's in close cooperation with the palliative medicine specialists from UCT who visit us weekly. So we've really, in a way, tailored our service package to be responsive to the needs from the other colleagues and the community. I mean, the question regarding what is relevant for a Q&I versus a field hospital is also important to note that the quarantine facilities don't have the level of nursing staff that we have. So patients that go there obviously have to self-manage and be able to be quite independent in their own care. And that's so we have a good relationship, making sure that when patients are discharged, that they are discharged to the right process. So the whole flow from the community through the acute hospitals into the CTICC and out back to the community either direct or via the Q&I facilities is managed very well. And I think what also is the other beauty is that we have the allied team colleagues as part of the multidisciplinary team within the CTICC, including social workers. So we really make sure that through family conferences over WhatsApp or video calls, that we really plan safe discharges so that patients, when they are discharged, it is done so safely with a good continuity of care. So
Thank
bringing
you,
in
Klaus.
those family medicine qualities.
No, absolutely. And I think that, this webinar, I think, just shows there's so many issues that need to be elaborated. There's so much more sharing that's needed. I mean, this topic itself, just looking at field hospitals and how they function, is a discussion of its own. I'm just going to raise one or two more questions, and I think we'll stretch it a little bit. Our audience will decide when we switch off. We actually we're at about 120 participants. We're down to 105. I think once it goes below 100, I'm stopping. So you tell us when you feel your attention span's dropping. But we'll try and answer the few questions left and then close it. I think there was one issue raised in the questions that we haven't quite dealt with and would be useful to go to that. And that's the question of staff becoming ill, and the fact that the PPE, how is that managed, and the impact on services. How is that been worked out in your settings?
Well, I'll comment briefly, and I'm sure the others have got other insights, but I do know that one of the learnings that we made, particularly in the hospitals, is that a lot of the staff that became positive did so from the cold stream, because of a sort of a sense that somehow, okay, I'm in the cold stream, this is safe, I don't need to take the same precautions, I don't need to use as much PPE. And in fact, I think the initial recommendations, didn't necessarily require you to have the same level of PPE in the cold side. So I think one of the things we've learned is that in essence, nowhere is safe. And that we need to provide PPE, and in both streams, and take precautions. I don't think PPE has been a major issue in terms of the supply as yet. I think that has been okay as far as I know. And maybe let others comment on your question as well.
Yep. Any other comments about staff and how that's experienced?
So in our experience, PPE has been carefully managed, because there is an awareness that there's a limited supply of PPE, but it hasn't been depleted. So, for example, our doctors and nurses would use an N95 mask for up to 3 to 4 days. And then replace it. We simply don't have enough N95s in stock to supply everybody with a mask every day. But I really think Bob is right when he alludes to the idea that our issue around PPE, it's well, at a primary care level, I can't really speak for a tertiary environment, which is where possibly COVID is far more concentrated. But at a primary level, it's really about behavior change across the board. Regard everybody as potentially COVID positive, and regard yourself as COVID positive, and just behave like that on a day-to-day basis. That's the safest you can be.
Well, I think they just need to insist on wearing and getting PPE and making sure they have it without it. I don't work without it. But what is happening with actually people getting ill and services collapsing? Michelle asked that question about collapsing services. Are you experiencing that in primary care?
Well, I think it is an issue, Shabir. I was informed yesterday by one of the family physicians that from Heidelberg Hospital, that the number of staff now that are off sick because of COVID-19 now makes it very difficult for them to maintain 2 separate streams with the staff that are remaining. And they're even considering now essentially putting everything back into 1 stream, because that's the only, that's all they have left to manage, So it is, I think, is becoming an issue. I think Zameer maybe wants to say something.
Yeah, Zameer, go ahead.
I think that this is going to become an issue for everyone around the country. And I think it's really important to kind of flag up front and just prioritize healthcare worker safety. So, for example, at Grootskee, 1 in 4 staff have already been infected. Across the province, I think we had almost about 3,000 staff. And interestingly, more than 85% of the staff that have been infected are actually in the public service. Yeah. So quite a big, discrepancy. I think, and it's been interesting to understand some of those kind of how the staff have been infected. And some of them, kind of the usual what we're hearing around tea rooms and that kind of thing, but also, some sharing transport, etc. I think the other thing that we can do and must do is make sure that healthcare worker testing is prioritized at all costs. And so having a healthcare worker wait even 3 days or 4 days for a result is unacceptable. Mm. And so what absolutely did happen is that when there was a crunch on kind of testing capacity, we saw healthcare workers waiting, long periods of time that I think compromised the kind of situation. But I think this itself could be a whole kind of webinar on how to manage staff.
Yes. No, thank you, Zameer. I think that we have got questions. There's some that that have come on the group, and I'm going to be trying to lump them. And I think we are kind of almost ready to close the webinar. So I think the question that have been raised about some of the comorbidities, Chanel asked about obesity. Michelle asked about people who are dying with no seemingly comorbidity. And I think that you've mentioned it, Neal, about targeting your testing at high-risk patients. So what are the sort of thoughts you'll have? I mean, I know that your testing strategy has been focused a bit better. Your turnaround times, I think, have improved. Do you want to share a little bit, maybe Mahmoud, Hassan, maybe about how you are looking at narrowing things down to get the right kind of focus, turnaround testing and targeted testing?
Yeah, so I think, as I mentioned earlier on, our testing strategy is focused on those over the age of 55 or those who have comorbidities. So it's, if you're under the age of 55 and you have a comorbidity, you are then prioritized for testing. And that's because we have limited lab capacity. So we've had to do that. And that's based on the data that we have, that those people who are hospitalized, those people who are dying, are the ones who are have the age risk factor, or alternatively they have the comorbidity risk factor. But of course, there's
obesity?
Sorry,
obesity.
Yes, I'm coming to that. So, so most of our deaths we know fall into that category, but obesity has come up as an issue. It's something that's not routinely measured, and that's the challenge. So we have started, my colleague who is on the call here, Dr. Zwigenthal, has initiated a pilot to experiment with different ways of assessing obesity at one of our hospitals. And we're going to see what comes out of that and then find a way that's practical. Because again, one doesn't want to add to the load of an already pressurized staff in terms of measuring this important additional risk factor. So we're starting to explore that, but it's not something that we routinely measure in our services. So that has been a bit of a challenge, and that's a neglected risk factor, and we have to acknowledge that. And lastly, of course, those who don't have comorbidities, again, age is the main way in which we pick them up. But of course, there is that small percentage that are under the age of 55 that don't have risk factors that unfortunately we do miss. The way we try and tackle that is, of course, we are monitoring people who have COVID-like symptoms, and we are regarding them as presumed COVID. But if they have any symptoms that are of concern, such as shortness of breath, they do get an additional assessment. And our criteria do include anyone who has severe symptoms and who might require hospitalization. And that's the safety net that we have in place. Thank you.
No, thank you very much.
97 participants now, Shabbir. So
I think we need to close up, but thank you very much. I think that there are lots of questions and lots of issues. I think that certainly, Bob, there seems to be two webinars, one on the hot stream, a little more clarity, and the other one on the field hospital. I imagine we can look at sharing experiences across South Africa on those two for some detail. But thank you all, Bob, to you and your team and the team of people in the Western Cape. We really appreciate you spending the time and energy. We've taken up more than, you know, the 1.5 hours. And to all the, you know, 120 people that have joined us, thank you all for joining us. Once again, don't forget, there's a webinar every Friday. We hope to make this something useful that you can find yourself being safe. So keep safe, everyone. Go well. Bye-bye.
Thanks everyone.
Thanks, Shabbir. Thank you.
Thank you. Thank you so much, Prof. Thank you. Thanks, Bob. Bye.